So I want to talk a little bit about the human health implications, following up a little bit from what Bob had to say yesterday on the what, so what, now what. So this will set the stage for these risk management interventions that Scott had mentioned. Now, always you got to have your wiring diagram slide. This is like, if you go to any resistance meeting, you always see this particular slide, or some variation of this theme. So what we're focusing on today would be the food animal use, and we've already learned from Scott this would be equivalent to your release component in a risk assessment. And we have the yellow box, which would be your exposure, your contaminated food, and then ultimately into your human section, which would be the consequence section. So really we're focusing in then today pretty much on that foodborne route of transmission. It's not to exclude or ignore the other pieces and parts of this map, but there's so much to talk about, we got to focus a little bit more. And since we're talking about animals, foodborne, that's really where I'm going to spend the majority of the introduction here. So that just kind of frames it up in totality. So when we talk about foodborne disease, how much is there? This has been one of those things that you can only estimate. And the recent estimates from CDC would suggest that for non-typhoidal salmonella, there's a 1 million case estimation and about 800,000 cases of campylobacteriosis. So that's all been published as of last year in Emerging Infectious Disease. Just estimates, and there's lots of papers and math that go behind that. So let's just kind of frame it up. That doesn't say anything about antimicrobial resistant salmonella or campylobacter. That's just foodborne disease cases. If we look at the trends over time, data from the FoodNet, and this would be in clinical infectious disease, depends where you want to start to say things have gone down. But if that's your baseline, then I think there's a general trend that foodborne disease in the U.S. is decreasing, and we can then determine which of the various pathogens that may be true for. But it would look like Campylobacter has gone down appreciably. And Salmonella has bounced around, but it's below that baseline of starting. So it may be a fair statement to say that in general, there's a trend for decreasing foodborne disease prevalence in the U.S. So foodborne disease, what about that? I pulled up two slides here that were generated by Busby's 1996 report. She worked in the ERS at USDA. So we talk about foodborne disease. When we talk about treatment outcomes, the reason I like this one is because here we look at salmonellosis. Don't look at the number of cases per se, because those will change. Again, it's a different estimation. But what happens to somebody that actually has salmonellosis? Well, 93% don't even go to a physician. They recover fully. 5% here did go to a physician and recovered fully. We don't know what the magic was there in terms of the treatment modalities. And 2% were hospitalized. And of that hospitalized minority, 94% recovered fully, and in this estimation here, 6% died. We don't know what the role of antibiotics in any of this was. These are just salmonellosis tracking and estimates. Similar for campylobacteriosis, same kind of thing, as if you want to follow that logic down. So once somebody's sick, they actually have to determine they're sick enough to invest in seeking medical care, and then that can take either the route for community treatment, say an outpatient clinic, private physician, or go to a hospitalized route. So we've got to kind of keep that in mind when we talk about outcomes. So I thought it might be useful just to kind of compare, well, what's the incidence of salmonellosis or campylobacteriosis in the U.S. compared to some other countries? It seems that Denmark was always held up as one country for comparison. So just if you look at cases per 100,000 population, you can see what those look like. So as we talk and use examples from other countries as to what should or should not be done, here's one piece of information that suggests the U.S. in comparison to at least one other country may not be doing so bad, yet still 13 and 15 cases per 100,000 may be still far higher than what's acceptable. And I think acceptability of risk, acceptability was one of the things that Scott had mentioned. So it's not all meat products. There's kind of a perception, as I become aware, that meat products are contaminated with lots of salmonella or campylobacter. But if we look at the NARMS, National Antimicrobial Resistance Monitoring System Executive Report 2009, here's what we have: culture positive for salmonella. This is just all salmonella, regardless of serotype, regardless of resistance status. You see, really we're looking at chicken breast and ground turkey, and not all of those are culture positive. In fact, probably around 20% here would be the highest in this particular year. If we look on ground beef and pork chops for salmonella positive, it's much, much lower. Same kind of thing for Campylobacter. Really, the only one here is in chicken breast, and that's pretty high at around that 50% mark. Interestingly, we don't even see ground beef or retail pork chops as being on the chart at all. We'll come back to that shortly. So that's just kind of the contamination piece. It's in that exposure box. So let's move a little bit now toward the antibiotic and kind of layer that in. Yesterday we had a little bit of discussion about the clinical predictive value of in vitro susceptibility test, or the MIC. And I got 2 points I'd just like to frame up here. As Scott mentioned, one of those other jobs that I do, I work with the Clinical Laboratory Standards Institute, Veterinary Antimicrobial Susceptibility Subcommittee on testing. So it's CLSI-VAST if you want another acronym to throw around. Setting breakpoints, clinical breakpoints for isolates of animal origin. And there's similar subcommittees for human pathogens. The whole idea here is when a culture is sent to the laboratory, a susceptibility test is run, and based on those results, susceptible or resistant, that information translates back to the clinician, be it a veterinarian or a physician, to guide them in the selection of which antimicrobial to use for a given patient. You want to stay away from the R, from the resistant, and move toward the S. Why? That's where we get into this 90-60 rule. This is a kind of a concept that's been recently outlined very clearly in JClin Micro in a recent supplement here in October, actually. And what that basically says is if you have that susceptible on a clinical breakpoint, you got about 90-95% assurance that you're going to get a favorable treatment outcome. But guess what? Even if you have a resistant, you still, in this particular example, 2/3 of the patients can be expected to respond to therapy, the 90-60 rule. Now, there's some caveats and other pieces, and one of those is you have to have an immunocompetent host, monobacterial infection, single antimicrobial agent, so that's about 25% of all cases. So when we do talk about bloodstream infections, you do generally have one pathogen, generally one treatment of an antibiotic. So this can apply very nicely. But we need to keep in mind that when we talk about resistance, it does not automatically equate to clinical treatment failures. So that's just one point to keep in mind as we look at surveillance data. So let's talk a little bit about those treatment outcomes. Look at meta-analysis, where you look at lots of studies and try to pool them together. Here's one that was published by Turnhag et al., looking at Campylobacter. And this would be not for the systemic or the bloodstream type, but just general campylobacteriosis. And what they found here, looking at fluoroquinolone treatment or macrolide treatment, is that what that basically did was shorten diarrheal illness by about 2 days or less. And there was some effect on decreasing the excretion of campy. That was the clinical outcome. For salmonellosis, in the Cochrane reviews, a 12-trial meta-analysis was looked at, and again, this was in the basically immunocompetent hosts. This did include infants, children, as well as adults, looking at clinical parameters. And they basically say it's got antibiotic treatment had no real positive value, and in fact, potentially some adverse drug reactions could be observed in their analysis. So they're really talking about very judicious human use of antibiotics for salmonellosis treatment. So I just want to kind of put that in the mix here as we keep these things in mind. And then one more piece to throw in from the latest GAO report. And this is a quote from Danish authorities on page 41. And it kind of sums it up if you really think about it. The antibiotic resistance is not listed on death certificates as a cause of death. It's really multiple organ failure. If you have sepsis, you might have kidney failure, you might have pneumonia, you might have any number of things, which is what the pathologist would actually put on that death certificate. So tracking and attributing antimicrobial resistance on a death certificate is kind of a challenge. So I found that kind of an interesting thing to bring to this forum. So again, the attribution, not all the salmonella, not all the Campylobacter infections in humans have a food, animal, or a foodborne origin. There are other ways, water, direct contact, and some of those things. So the epidemiology is very important. And we won't get into that because I'm not an epidemiologist. So this is kind of the what. And I want to just give you a few more slides here on the what. Keep in mind, and I'll show you some information, the antimicrobial resistant foodborne bacteria are a subset of foodborne pathogens. And that's important because when we talk about antibiotic resistance, or are we talking about foodborne disease interventions, or both? We talked a little bit already about similar antibiotic classes. I'll go through that kind of quickly here because it's already been well established. And then we already mentioned some of the estimated trends in the decrease of foodborne disease. We've hit a number of the indications already, whether it's prevention, control, treatment, or performance, so I won't spend time on that one. I think Mike had shared some of this information, the shared human use classes, just to catalog those. So there's quite a variety of those. I won't go into detail on those at this point. I would mention again, just to reinforce the point, that there are some of those shared classes with human use for growth promotion, poultry, swine, and or cattle. You can kind of see the list here. And there are some that are veterinary or animal use only, as depicted here by the red and not by the black and not the red. You've got to keep this in mind. So we talk about antibiotics. That's a very general term. We need to then drill down and say which antibiotic, and then look into that. Is that medically important? Is it used in animals only? So that resistance subset that I mentioned, data from NARMS again. Non-typhoidal salmonella, 80% of the human isolates are pan-susceptible since 2004. Pan-susceptible. So if you take that 1 million figure, and now you've got 80% are pan-susceptible, you can do some math on that. Non-typhoidal salmonella, less than 0.1% fluoroquinolone resistant from human isolate collections. There were none from retail meat or food animals. Interesting. Non-typhoidal salmonella, if you look at 3 to 4% of human isolates resistant to the third generation ceftriaxone since the year 2000. The data is in the reports. You just need to dig it out. In Campylobacter, about 40 to 45% pan-susceptible since 2005. So there's a value for antimicrobial resistance trending and analysis here. And there's lots of details on serotypes and multi-drug resistant bits and pieces. But if we focus on the flip side of what's susceptible, those susceptible bugs still make people sick. Do we want that? I'd prefer not to have salmonella, period, whether it's resistant or not. Let's flip it around. Major classes of antimicrobials used only in humans. And Bob touched on these the other day. So here's my list, and I think it's the same one, Bob, if you can correct me on that if I'm mistaken. So there's a whole bunch of antibiotics that have no use in food animals that are on this list and used for a variety of those hospital-acquired infections. So that kind of raises this question, well, what about this resistance gene transfer from foodborne bacteria to human pathogens? We hear lots about, we got reservoirs of resistance, and all those bugs in the animals can transfer their resistance genes to human pathogens. Maybe. Let's look at some of those epidemiologic connections. You've got to be at the same time, same place, in order for things to cause a transfer. You've got to overcome a lot of the resistance gene transfer pieces. There's restriction enzymes and all sorts of things that can get involved in that. And then even if you do have that transfer, somehow those pathogens have to amplify. You might have a bug, but you need amplification of that clone and spread within a human host. So as we look at the specific bacteria, having fun with all the pronunciations, how does that really occur? To what extent does that occur? So we just got to put it all together. So here's the conundrum that we're going to face. For those who have the veterinary degree, this is the current AVMA Veterinarian's Oath. We talk about the prevention and relief of animal suffering, which in the case of antibiotics, prevention, control, treatment, and the promotion of public health in the same sentence. So that really sets up this tension, this conundrum. There's a veterinary need for antibiotics, but there's also a human medical need for antibiotics. The zoonotic, the Campion, the Salmonella, and the bystander bacteria, the E. coli, and the Enterococci, they just get in the way. They're complicating the issue in terms of these competing needs for treating frank disease in both sectors. So that just kind of frames it up. As we think now about risk management interventions, where do these come from? So I've elected to use some of the international organizations, WHO, OIE, and Codex, to see what's been going on. Now, this is just another meeting in a series. So I've listed on the next few slides some of the more impacted meetings going back to '69. You can kind of see your favorite reports and topics. And I'm not going to spend any time on these. The point is, this issue has been studied since the 1970s, 1960s, if you want to go back that far, and continues today. So lots of meetings, lots of recommendations. What I tried to do is say, take them since 1997. What have these reports all got in common? What are the general recommendations? There's 5 of them. There's others, but these are kind of the top 5 in my opinion. Responsible use guidelines. There's a lot of stuff we can talk about there, whether it's directed to clinical practice for veterinarians or to general stakeholders that include multiple organizations like regulatory, pharmaceutical companies, etc. Resistance monitoring. We've already mentioned NARMS, that sort of thing. Antibiotic sales monitoring, Ron had touched on that. Regulatory controls. Bill Flynn will tell us more about that. And we've already heard about Guidance 152, and that's also similar things in other countries. And then research, kind of overlooked. There's been some requests for research on specific residue things, better dose duration, but research on novel interventions could be included in here. So these are kind of like the 5 key things, and the following 3 speakers will elaborate on those. And where do these get placed? If you think back again on our release exposure consequence, we're really working in this food animal and maybe the retail meat areas. We don't do a whole lot because we don't have control on the human health side of things. But that's what we're hoping to effect, is by changing things all the way back here, that it's going to decrease foodborne disease and the foodborne disease that has antimicrobial resistance associated with it. So we need to think in terms of that continuum. You do one thing on the domino set, reduce it a little bit, and that's amplified and decreased as you go through the food chain. So now what? Where are we going with all this? Well, as we think about these risk management interventions, it's really going to start to reshape veterinarians' access to antibiotics and the practice of veterinary medicine. And I'm not sure we really know what that impact on public health and food safety is going to be. If we look at Denmark one more time, again, from the GAO report, this is a very interesting paragraph. It basically says they haven't really seen a whole lot of decrease, if any, in human antimicrobial resistance as a result of all of the interventions that have been put in place on farm. Sure, VRE went down, but there's data now that's showing it's going back up. It's very difficult to track that human health outcome for the reasons that I elaborated earlier. It's very difficult. So keep that in mind. U.S., what have we done here? Well, as we know, in 2005, the water medication Bacterial was withdrawn by order of the FDA from poultry use, chickens as well as turkeys. So what's happened as a result of that? Well, if we look at NARMS data and just draw our line here at about 2005, and probably realistically, poultry producers were not using it a little bit before that particular September date. Well, human resistance is kind of trickling back up here, and this is humans, chicken, breast, and chicken. You can kind of see that there's not been a downward trend necessarily. It's still up there. Cause and effect attribution, we'll have to sort that out. It's just data, and I'm not making a link, but That's what the NARMS data is suggesting. On the other hand, look at macrolide use, which would be a tylosin or erythromycin in poultry. It's been flat since the get-go and continues to be that way. Different antibiotic class. So that's why it's very difficult when we talk about antibiotic resistance as though it's one thing. We need to drill down to the bug, the drug, host species. It's critical to do that, and I think Scott Brown yesterday had mentioned if we're going to have effective interventions, it almost has to be to that level. Keep that in mind on our risk management interventions. Just to contrast again to Denmark, yes, they've got some ciprofloxacin, I think that's the right line there, resistance out there, domestically acquired. Interestingly, while I can find it in broilers, it's not on Danish broiler meat, so where's that coming from? Interesting stuff there, perhaps. Just as a compare and contrast, again, I'm not making associations, just showing some information. So where do we go? So what now? American Academy of Microbiology had a colloquium. If you can imagine, about 40 microbiologists meeting in France, locked up in a very nice chateau for about 3 days to talk on this issue. Very boring, very boring. Great wine, but very boring. Here's what the outcome, an ecologic approach to an old problem. It really emphasizes prudent use of antibiotics, however that may be defined. And it basically talks about finding a way to coexist with resistance. I don't think we can turn back the clock to make things pan-susceptible. And even if we did, do we still want pan-susceptible salmonella or campylobacter contaminating retail meats? I think not. So we need to be smart, come up with strategies that minimize and contain to the best extent possible, and hope that that improves over time. Now here's a slide that I want to leave you with for lunchtime consideration. Looking ahead, we're talking about risk management interventions. What will be the impacts? And we talk resistance. But if you start thinking about 50 years, the world population is going to need 100% more food. We've already hit that 7 billion people mark. But in 50 years, maybe less. 100% more food. Where is that coming from? Well, 70% of that has to come from technology of any sort. It doesn't all have to be chemical technology. It can be crop rotations. It can be all sorts of technology. But we've got to rely on that because we can't keep generating more cropland. It's going mostly for urban and suburban development. This is all coming from a white paper that's available online if you wish to read more about that. We need to keep in mind that antibiotics are one of the technologic tools that enable more animals, healthy animals, to enter the food chain to help address that need for increased food globally. So I'll leave you with this tipping point slide. If anyone's a Malcolm Gladwell fan, the tipping point scales. What causes an issue to go one direction or another? So here's kind of your compare and contrast. And I just have a number of bullet points, and you can read them quicker than I can elaborate on them. These are just some of the issues I think we're dealing with in this particular forum. You'll hear more from the following 3 speakers. So I'll just leave those with you at this point. The need for increased food production, as well as the balance that needs to be achieved between public health, food safety, animal health, and welfare.